Good afternoon. I am Stephanie Wanza with ASFA, and we welcome you to our Pain Epidemic Practical and Evidence-Based Solutions to Live Pain-Free webinar. We thank you so much for joining us on today. We have Dr. Jay Greenstein, who will be our presenter on today. We're so happy to have him, and also Dr. Bert Fritz, who will be answering all of our questions. We want to invite you to sit back, relax, and go ahead and allow our presenters to give you some very helpful information about the pain epidemic and pain management. Just a little bit about Dr. J. He is a CEO of KZO Health Companies. He is a certified chiropractor, and he has been in the chiropractic industry for many years. He's well-renowned all over the United States as a prolific chiropractor, researcher, and presenter. So we want to thank him so much and his staff for coming and presenting this information to us on today. Again, we will have a Q&A session at the end of the presentation. If you would like to ask questions in the chat, Dr. Fritz will be happy to answer. And at this time, I'll go ahead and let Dr. J give his presentation. Thanks so much.
Thank you so much, Stephanie. I really appreciate being here today. I'm very excited. It's been a while since I've been able to present this information, so I'm really excited. I know we've got a huge audience, and I'm really hoping that it creates great content and great value for you. And again, we want it to be as interactive as a webinar could possibly be. So if you've got questions, please feel free to put them in the chat so we can answer your questions and be specific to your particular needs. So today's topic of conversation is the pain epidemic, practical and evidence-based solutions to live pain-free. And again, the evidence-based piece is really important. As Stephanie said, I live in a world of clinical care delivery as well as clinical research. One of our organizations that we run is a 501c3 nonprofit clinical research institute. We're part of a large multi-year NIH grant right now. So we're well-versed in the scientific literature and, most importantly, the application of the scientific literature to clinical practice to drive the best possible outcomes for our patients. So, usually when I'm live in front of a live audience, this is always the first question I'll ask, like, okay, what hurts? And people will raise their hand like, my back hurts. And somebody else will raise their hand and be like, my knee hurts. And I'm like, okay, how many people have low back pain? And like half, 2/3 of the audience raises their hands. Or neck pain, half, 2/3 of the audience. Same thing with knees and shoulders. Like there's just a lot of folks out there dealing with a wide variety of musculoskeletal challenges. And whether you're, a construction worker or a desk jockey, a mom or a professional athlete, all of us at some point in our lives, based on the evidence, deal with some sort of, or sometimes multiple, musculoskeletal injuries. And so if you've got something that you're dealing with, feel free to put it in the chat, share with us what you're dealing with, and at some point, maybe at the end, we can talk more about the challenges that you're facing. Stephen Covey said, to begin with the end in mind means to start with a clear understanding of your destination. It means to know where you're going so that you better understand where you are now, and so that the steps you take are always in the right direction. And my goal for all of us today is to help point you in the right direction as it relates to good musculoskeletal health. And we need to talk about what that end goal actually looks like. Like, what does it mean to have good musculoskeletal health? What does it mean to live a pain-free life? So there are certain laws of good musculoskeletal health, and I want to share those with you first because this truly is the destination. So musculoskeletal health is the balance of both mobility and stability. And I'll share a bit more detail around that right now. So how do you have good mobility and stability? Well, you must have full joint range of motion if you're going to have good mobility. We know from the evidence that when joints don't move through their full ranges of motion, the first thing that happens is that nociceptors or pain receptors inside the joints fire. Secondarily, we know from the studies that when a joint is immobilized, within 2 weeks of joint immobilization, we start to get degradation of the cartilage inside the joint and muscular atrophy for the muscles that actually actively move that joint. So when a joint is not moving through its full range of motion, we get pain, stiffness, discomfort, but we also start to get the beginning stages of osteoarthritis. And so it's not just about how we feel, it's really more about how we function. Nobody likes pain, nobody likes stiffness, but ultimately at the end of the day, nobody really likes arthritis. And so for us to be able to understand good musculoskeletal health, we have to understand that our joints must move through full ranges of motion. Next, in order for our joints to move through full ranges of motion, we must have good muscular flexibility. If my elbow joint inherently has full range of motion, but my bicep muscle is too tight to allow for that range of motion to occur, what's the point? So good mobility comes from a combination of full joint range of motion, but also the muscles functioning at the appropriate length to allow for that range of motion to occur. Now, if we want good stability, we have to have what we call good proprioception. So again, if I was in front of you guys in an audience, we would go through this little exercise where I would have you stand up, and you can even do this at home if you like. You can stand up, and I would say to you guys, okay, what I want you to do is I want you to actually squeeze your lower back muscles without moving. And usually we have people partnering up, and one person has, their fingers on the other person's lower back, and can they feel the muscles moving or can they not? And for the vast majority of people, nobody really knows how to activate their lower back muscles, their erector spinae muscles. And so why is that a problem? Well, if we can't control our muscles, which are designed to move and stabilize our joints, are we more at risk or less at risk of having an injury? And the answer is, I'm sure you know, is that we're more at risk. How did Michael Jordan take off from the foul line and slam dunk between 3 defenders, land on his foot, and not get injured? It's because he has great proprioception. Proprioception is knowing where your body is in space and being able to control it. And so if we are able to stand up, squeeze our lower back muscles, activate the muscles that stabilize our spine, we are much less likely to have an injury to our lower back because our muscles are firing at the right time and in the right sequence. If we don't have good proprioception, which is often mostly disrupted by a previous injury, if we don't have good proprioception, then we are more inclined to have an injury. And in fact, one of the most accurate predictors of any future injury, you guys, I don't care if it's your neck, your knee, your elbow, your ankle, your back, one of the most accurate predictors of future injuries is past injury. And again, if I was in a room and I had you live, I'd be like, okay, why do y'all think? And someone would raise their hand and be like, past injury. It's because people don't take care of the problem. They don't fix the function. They just stop treating the problem when the pain or the symptoms go away. And that is absolutely 100% correct. Study after study after study has shown that patients stop care too soon. They stop when symptoms go away, but not when their function is fully restored, not when they're back to full strength, and therefore they're at risk for having the injury reoccur. And then speaking about developing full function, the fourth element of good musculoskeletal health, which I'm sure is not a surprise to anybody, is having good muscular strength and endurance. Our muscles need to be strong to support us. Our muscles need to have endurance if we're standing for long periods of time. And I would even argue if we're sitting for long periods of time to maintain adequate posture. So we need to have good muscular strength and endurance as well. So again, good rules for musculoskeletal health: full range of motion, appropriate muscular flexibility, good proprioception, knowing where our body is in space and being able to control it. And then lastly, appropriate muscular strength and endurance. And in short, having great musculoskeletal health takes work. Michael Jordan said, some people want it to happen, some people wish it would happen, others make it happen. And I'm sorry, you guys, when we look at the scientific evidence, the large body of scientific evidence, here's what we know. Musculoskeletal conditions are often the leading cause of disability worldwide. We also know that most patients tend to go to a bottle first, meaning Tylenol or Advil or some quick fix, right? Rather than putting in the work to develop good musculoskeletal health and ensure that they don't have these problems occur in the first place. So again, I want to share with you, this is what the evidence says. If we want good musculoskeletal health, we've got to put some work into it. So what's the alternative, right? If we don't put the work in, what's the alternative? And what we know, again, leading cause of disability, number one leading cause of disability worldwide in 2019, back and neck pain. And invariably, whenever you look at the year, in 2018, it might have been depressive disorders first and back and neck pain second. But these two go back and forth on a regular basis. Now think about it, guys. If you've got chronic neck and back pain, are you probably going to be more depressed? And the answer is yes, you will. And there's also great evidence around the fact that people who are depressed are more susceptible to back and neck pain. These two things are completely related. We are one human body. We are not parts. We are one human body, and all of these things are very interrelated. So the alternative is, if we're not going to do the work to take care of our musculoskeletal system proactively, we're probably headed down a path of having some sort of disability in our current and or later years. In the US, 25 plus million people suffer from pain daily, and 23.4 million Americans report a lot of pain. This comes from NIH, you guys. This is the evidence around pain in our country. The Commonwealth Fund did a study of 11 industrialized nations. The US had the most expensive healthcare with the worst outcomes. And that's because our system, our healthcare system, our society is geared towards magic pills. Magic pills. I can take a pill, it'll fix this. You'll get 10,000 side effects, but I can take a magic pill and it will fix this. Now, guys, full disclosure, I'm a chiropractor. I don't prescribe medicine. I don't want to prescribe medicine, but there are times when our patients need medicine. There are times when our patients need medical interventions. There are times when our patients need injections. There are times when our patients need surgery. I am not blind to those facts at all. But when I share what the current evidence says about conservative, non-invasive, non-pharmacologic care versus drugs first, it no longer becomes my opinion. It's not about me. It's not about my opinions. It's about the evidence. And I'm going to share that with you as we talk about how we deal with these problems and solve them for good. Chronic pain statistics, 11 to 40% of US adults are living with chronic pain. 8 in 10 patients with chronic pain are affected with severe depression. We just talked about that. 1 in 4 people with chronic pain have been diagnosed with a sleep disorder. Y'all know, if you've got pain, it's hard to sleep. And that affects how we're functioning and performing in our daily lives. How can we take care of our kids? How can we connect with our spouses? How can we do our best work if we're not sleeping well? And 10% of the world's population, 10%, 1 in 10 people are affected by chronic pain. So it literally is a worldwide epidemic. What is the most common chronic pain condition? Low back pain. The 4 most common types of chronic pain, 27% with low back pain, 15% headaches, 15% neck pain. By the way, it is literally not surprising that those two numbers are exactly the same, because many, many, many headaches are organically caused by dysfunction in the cervical spine in your neck. And then 4% of people are dealing with facial pain. TMJ pain is a very common syndrome that we see on a regular basis. The disability by age is a really interesting graph. Again, this was looking at different age groups and like what were the most common problems by age group. And what you can see is that mental health concerns were much more common and prevalent as the younger populations, but that flipped when we get into our 40s. And all of a sudden, musculoskeletal disorders become the #1 years lived with disability caused by all these different kinds of musculoskeletal conditions that I just mentioned. So when we're younger, we're dealing with more mental health challenges. As we get older, we're dealing with more physical conditions. And that becomes really hard to manage if we've not managed our musculoskeletal health proactively in our younger years. Exercise, good nutrition, getting to the gym, appropriate stress management, getting good sleep, having good posture when we're sleeping, having good posture when we're doing our household activities, having good postures when we're sitting in front of a Zoom or a webinar watching for an hour. So all of these things can contribute to either good or poor musculoskeletal outcomes. Why is chronic pain an epidemic? Well, again, the most common way to treat chronic pain is pain medication. And I'm going to ask you, these are important questions, Acetaminophen. It's an over-the-counter pain medication. It literally works in your brain. It doesn't work on your joint. It doesn't work on your muscles. It doesn't work on your joint proprioceptors. It doesn't work, in the gym. You don't take acetaminophen and all of a sudden get stronger, right? So again, do pills ensure full range of motion? And the answer is no. I don't care. And by the way, I don't care if it's acetaminophen. I don't care if it's Advil. Like, the answer to that question is no. Do they ensure muscular flexibility? No. Do they drive better and more accurate joint position sense, knowing where your body is in space and being able to control it? The answer is no. And does it guarantee good strength and endurance? The answer is no. Now, folks, again, I'm not saying that there aren't certain times when maybe a patient needs an over-the-counter anti-inflammatory, and for a short period of time, maybe that's appropriate. And I'll actually show you what the evidence says around when it's appropriate. I'm not saying that sometimes, if that's the only solution for you, should you not take Tylenol if that is the only thing that you can do in the moment so that you can decrease your pain? I'm not saying that. I'm not that binary, yes or no, black or white. But what I'm saying to you, and the message that I'm trying to get across, is that if we want good musculoskeletal health, if we want to get out of these painful chronic conditions, acute and or chronic conditions, we've got to do the work to ensure that we're actually creating musculoskeletal health from the inside out, not from the outside in. Again, the number one predictor of future injury is past injuries, and that's because patients and physicians stop treating the problem when the pain is gone. And again, your symptoms can go away, but that's a whole lot different than your function. And one of the analogies I like to use is this concept of a very unfit human being eating McDonald's every day of their life and, just going about their business. Maybe they're a little overweight and maybe they're pre-diabetic. And all of a sudden they have to walk up this really long hill. And as they're walking up the hill, their breathing gets labored, their chest starts to get tight, and when they're getting almost towards the top of the hill, they're starting to get chest pain. Now, we're worried about a myocardial infarction. We're worried about this person having a heart attack. They sit down, they rest, their exertional angina goes away. Are they healthy? Their symptoms are gone. They must be healthy, right? But they're not. It's just that their symptoms are gone. If that human being is not going to die of a heart attack in the next several years, they've got to do the work to ensure they actually reverse what they've done to their bodies. The musculoskeletal system, you guys, is literally no different. You got to do the work because you can't just judge your condition or your conditioning on your symptoms or lack thereof. In the Journal of the American Medical Association, in an article entitled Worsening Trends in the Management and Treatment of Back Pain, they concluded, despite numerous published clinical guidelines, management of back pain has relied increasingly on guideline discordant care. What that means is that providers are not delivering care to their patients based on the highest level of scientific evidence, because clinical practice guidelines are the highest level of scientific evidence. They're an amalgamation, they're an aggregation of randomized controlled clinical trials, systematic reviews, and meta-analyses. All of these are high levels of scientific evidence. And they go on to say, improvements in the management of spine-related disease represent an area of potential cost savings for the healthcare system with the potential for improving the quality of care. Now, why they use the word potential, I really don't know. There's strong evidence around this clinically. There's strong evidence around this as it relates to cost. And so the idea that people are actually receiving care from their healthcare providers that does not align with the scientific evidence makes my head spin like The Exorcist, baby. And for those of you who watch The Exorcist, you know exactly what I'm talking about. It is why our healthcare system is so ineffective. Look, you guys, you can turn on the nightly news. Every single commercial is about a drug. Drugs do not make people healthy. Lifestyle habits make people healthy. And I think I'm just trying to emphasize that point. Let's take a new injury, for example. Let's say you're running around the front yard, you're playing with your kids, and you sprain your ankle. Now, by definition, a sprain is overstretching or tearing of ligaments. and ligaments connect bones together. They literally are that connective tissue connecting bones that create a joint. A strain is overstretching or tearing of muscles or tendons. They connect, tendons connect muscles to bones. When you sprain an ankle, you have an inflammatory process. There's literally cellular, physical damage, mechanical damage. You get vasodilation, more blood comes into the area. That's why your ankle swells. You get what's called secondary cellular hypoxia. The healthy cells literally are drowned by all of that blood and lymph rushing into the area. And then scar tissue starts to form relatively quickly. It's like when you cut your skin, pretty quickly you start to develop a scab. That's the beginning stages of scar tissue, and that happens with the formation of fibroblasts. So how do you mediate this? Well, the simple way to think about this is just you rice it, right? And I'm not talking about rice that you might eat at a restaurant. I'm talking about rest, ice, compression, elevation. So let's talk about ice first. There's a lot of controversy about icing. I mean, I can't tell you. There's studies that show that it works. There's study that shows that it doesn't. You know, I've been doing this for almost 30 years now, and I can say, based on, again, some of the evidence that exists in the scientific literature, but also my clinical experience, what patients report, ice tends to work really, really well. And what we do, we prescribe ice in an acute injury, 10 minutes on, 10 minutes off, and you repeat that process as much as possible. Why you do that on and off is because when you ice the area, you're vasoconstricting, you're decreasing blood supply to the area. And what happens is you get reflex vasodilation when you take the ice off. So you're literally helping to push out that old blood, and you're improving circulation to stimulate cellular healing. It literally prevents too much blood from entering the area, and again, creating that secondary cellular hypoxia. Creates that pumping effect and decreases pain, edema, and spasm. The next is rest and compress. So literally, you want to rest as little as possible. You want to move the injured area within the limits of pain and stability, and that allows for a stronger scar. So Jerry Rice is a really good example here. Like Jerry Rice tore his ACL, he came back in the same season. When they did the ACL reconstruction surgery on him, they put him in a passive mobilizer right away. Why did they do that? And I mean like literally right after surgery. Why did they do that? Because they wanted to ensure that with that motion they were creating within the limits of pain and stability, it literally was telling the fibroblasts that lay down the scar tissue to do it in a very organized way that aligns with the stress across the joint so that it would be laid down correctly and it would create a much stronger piece of connective tissue. So when patients sprain their ankles, we'll have them do, all of the icing, but in addition, we'll have them do what's called ABCs, right? Like we want you to start moving that ankle and draw the alphabet with your foot. So you draw an A, you draw a B, you draw a C to get that motion back into the joint. That does a few things. It helps to pump out that blood and lymph that's just sitting there, but it also helps to create the scar tissue in an organized way along the lines of stress of that particular joint to create a much stronger scar. Great evidence around this. This is not opinion. If you have an injury like this, you definitely want to start moving that injured body part within the limits of pain and stability. Now, let's take the extreme. If you fracture your ankle, obviously you're not moving that body part within the limits of pain and stability. You're going to the ER, you're going to the orthopedist, you probably need surgery, right? Those are indications that are different than what we're talking about with a sprain strain. Okay, I just want to be clear about that. Elevation, any injured body part you want to actually raise above the heart whenever you can to help stimulate lymphatic drainage away from that injured area. So we often get this question like, okay, so I'm racing at home, I'm still having some pain, I'm still walking with a limp. How long should I wait before I go see a healthcare provider? So I can't see the chat right now, but I would love to know, actually, can I see? I know I can't, but for those of you that are watching, I would love for you to put into the chat, like how many of you all think it's 3 days? If you think it's 3 days, put 3 days into the chat. If you think it's 8 days, put it into the chat. And if you think it's 14 days, put it into the chat as well. So how long do you think it would take if you're still symptomatic, if you still have functional deficits, how long do you think you should wait before you seek out appropriate treatment? So go ahead and put that into the chat. The answer is actually 8 days. What the scientific literature tells us is that when a patient presents with an injury after 8 days of having it and not having any intervention between the injury time and seeking out appropriate care delivery, treatment time can take up to 1.5 times to 2 times longer. So getting into an appropriate intervention matters. Starting your ricing early matters. Making sure that if you're not resolved, both functionally and symptomatically, getting into an appropriate treatment plan, those things matter to speed your recovery time. Now, if you're typically going to a PCP, you sprained your ankle, you go to the PCP, they may give you some NSAIDs, they may give you some COX-2 inhibitors, they may give you pain medication, they may give you muscle relaxers, they may even give you opioids, God forbid, but they may do that. Or maybe they even give you, especially in chronic conditions, they may give you cortisone injections. I will tell you and share with you in just a moment what the evidence says about all those interventions as it relates to it being the first intervention. I'm going to share that with you in just a moment. But that could happen if you go to your PCP, maybe the orthopedist, or another, allopathic provider. What has been shown to work in the literature is really important. And because we don't want guideline discordant care, we want appropriate care delivery. So these are the rules for appropriate treatment. First and foremost is active and passive joint mobilization and manipulation, depending on what body region we're talking about. There's great evidence around joint mobilization and great evidence around joint manipulation, specifically as it relates to spine-related disorders. Dynamic stretching and soft tissue treatments. We've got to work the soft tissue, help the scar tissue align appropriately, get rid of the swelling, get rid of the edema. All of that requires appropriate dynamic active stretching. It also requires a lot of soft tissue treatment that's done typically by the healthcare provider to push the swelling out, to align the scar tissue appropriately, to ensure that the inflammatory process is working for you and not against you. Physical therapy modalities, again, oh my God, lots of really good evidence about emerging technologies that are out there. Dr. Birch, and I were just in an in-service for shockwave therapy. I was looking at the evidence around shockwave therapy just a couple of days ago. Like paper after paper after paper is showing really good evidence for a wide variety of conditions, neurologic conditions, musculoskeletal conditions, et cetera. Pulsed electromagnetic waves also have been shown to be very helpful. Using low-level laser therapy, electrical stimulation, all of these PT modalities are shown to decrease pain and improve function. And guess what? You know what the side effects of these are? Nothing, zero. Next would be appropriate proprioceptive rehab. There are exercises, very specific exercises that we give our patients to help them teach their body where they are in space. A great study was done by a physical therapist up in New York. He's worked with the Jets, he's worked with the Rangers. His name is Tim Tyler. And he did a study on a group of high school athletes, football players, on ankle sprains. And what he learned is, one, the most accurate predictor of a future ankle sprain was previous ankle sprains. And two, when they did preseason proprioceptive training on those athletes, they reduced ankle sprains by 77% for the entire team. So when you're rehabbing an injury, in order to decrease the probability of it happening again, proprioceptive rehab, teaching the body to know where it is in space, is critically important. When you tear connective tissue, you disrupt proprioceptors, so you must retrain them to know where the body is in space. I don't care if you don't have any more pain in the ankle. I don't care if you don't have any more swelling in the ankle. That's not the focus of intervention. The focus is to make sure that the problem doesn't return, and proprioceptive rehab is a really critical part of doing that. There's a ton of balance training, progressive exercises that we do in order to ensure these problems don't return. And then lastly, appropriate strength and endurance. Now, would we ever strengthen a joint that doesn't have full range of motion? No. Would we ever strengthen a joint that doesn't have full muscular and appropriate muscular flexibility? No. Would we ever load a joint that doesn't have adequate proprioception? No. There is an order, there is a method to the madness, there is a recipe here that has been proven to work. And so these are the things that must be done in sequential and sometimes in concurrent order. How long should most musculoskeletal conditions take to be treated? An uncomplicated case, meaning it's not chronic, you haven't had a bunch of previous episodes before, there's no neurologic deficits like a severely pinched nerve where you've got muscular atrophy or weakness or other functional neurologic deficits. 3 times a week, 2 to 3 times a week for somewhere between 2 and 8 weeks. By the way, the young athletes respond really, really fast. As we get older, we don't respond as quickly, but that's a range of treatments that might, a range of care delivery that might be needed. For complicated cases, it's typically going to be longer. If you've got neurologic deficit, you've got a spine condition, or you've got a peripheral nerve condition, and you've got neurologic deficits, it's going to take longer. Most likely, you've had the problem longer, and so therefore, it's going to take longer to fix. So somewhere probably between 3 to 16 weeks, between 2 to 3 treatments per week, excuse me. One thing I also want to share with you guys, there are, and this is for musculoskeletal care, just like you're dosed, like you get sick and you need an antibiotic, there's a dosing schedule, right? You take it for, now they have antibiotics that you take once a day, but the doctor says, what does the doctor say to you? They say to you, don't stop taking the antibiotic when you feel better. You must continue the course of care. Musculoskeletal care delivery is no different. You don't stop just because you feel better. And there are specific dosing studies around care delivery. What we know is that the more frequently patients are treated early in care, the faster they get better. So think about this, right? Tom Brady, I'll use Patrick Mahomes. Patrick Mahomes is a great example, right? If you're a football fan, you know that, and you were watching the game last week, Patrick Mahomes had a medial ankle sprain. Somebody landed on his ankle, and he tore the ligaments on the inside, the medial side of his ankle. How many times a day do you think Patrick Mahomes is going into the training room? You think he's doing it once a week? You think he's doing it even twice a week? He's going in multiple times per day in order to have that ankle worked on over and over and over again. Now, not too many of us that are on this webinar right now are elite NFL quarterbacks, right? So maybe we don't need to go into the physical therapist or the chiropractor or the pain management or the osteopath or whatever, the acupuncturist, the naturopath. Maybe we don't need to do that 3 times a day. But the point that I'm making to you guys is the more work you put in at the beginning of care, the faster you get better. And I know that's hard with people's schedule. They got kids, they got this, they got work. I get it, I understand. But if you want a faster recovery, the earlier, more frequent interventions are significantly better outcomes, faster outcomes than dragging it on for periods of time. The other analogy that I would use is if you go to the gym and you go in once a week, what kind of gains are you going to make versus going in 2, 3, 4 times a week? So just think about that. It's a seed I'm planting so that if you ever need musculoskeletal care delivery and somebody's making a recommendation to you, just understand it's an evidence-based recommendation to get you better faster. So let's talk through some common conditions. We're about halfway through, actually maybe more like 2/3 of the way through. I want to talk through at a high level some common conditions. Understand there are commonalities for common conditions, but every single person who walks through our office with low back pain is different. Might they all have tight hamstrings, or most of them? Sure. Might they all have some level of joint dysfunction? Sure. But some might have tight hip flexors, some may not. Some may have excellent proprioceptive skills, some may not. So every person is different, but I'm just going to give you a very 50,000 foot view, high-level view of kind of what we think about when we see these conditions in our office and if it applies to you. And again, I'm hoping to have about 10 to 15 minutes of question and answer time at the end, so feel free to put that into the chat. So again, at a high level, the treatment interventions that you're going to follow or want to follow or your providers are going to want to follow are just what I just mentioned. Like if you're making a cake and you use flour but you don't use the eggs, like you're probably not going to have a very delicious cake. So if you follow the recipe, you're probably going to get a much better outcome. So let's start first as it relates to disc problems in our spine, low back pain. Mechanical low back pain, again, is one of the most common conditions that we see with our patients. Mechanical low back pain is where your joints in your spine don't move through full ranges of motion. What do your muscles do typically when that happens? They're going to tighten up to protect the area. Now you've got superimposed muscle spasm, which limits motion even more. That may cause other joints above and below those regions to actually move more than they're supposed to compensate so that you can move through full overall range of motion, but intersegmentally at every joint in the spine, you're not. Some may be moving too much, some may not be moving enough. Again, good musculoskeletal health is the balance between mobility and stability. And so over time, if that joint dysfunction in that mechanical low back pain, that joint dysfunction in your spine is not resolved, it will lead to disc problems. Another analogy that I use to explain mechanical low back pain is if I asked you all to hold your thumb like this for the next 25, 30 minutes before this webinar was done, how would that feel? Like, how would it feel? And normally if I'm in front of a live audience, it'd be like, it would be stiff, it would hurt. Like, of course, wouldn't feel good because we talked about earlier, when joints are not moving, nociceptors, pain receptors fire inside that joint. How do we get it feeling better? What do we need to do? We need to put motion back into the joint. So we can't adjust our own spines. So in order for us to actually get that joint moving, we do spinal manipulation, also known as the chiropractic adjustment, to get those joints moving through their full ranges of motion. If somebody does not have that intervention when it's just mechanical low back pain, the evidence says, guess what? It's going to lead to disc problems over time. Because I mentioned earlier, when joints don't move through full ranges of motion, we start to get degradation of the cartilage inside the joint. And in the spine, we start to get degradation of the discs. When we don't have motion in the discs, it's just a big jelly donut, for lack of a better analogy. When that jelly donut doesn't stay mobile, the jelly starts to dehydrate, and we start to get a very stiff, very non-flexible disc, and those discs can then herniate into where the spinal cord and nerve roots are. So how do we address all this? Again, you follow the recipe as it relates to specific disc problems. You've got severe low back pain. You're antalgic, meaning that you're kind of leaning away from where the disc has extruded or herniated. You've got some leg pain or some gluteal pain. Maybe you're having difficulty walking. Maybe your leg doesn't feel quite as strong. Maybe you've got numbness or tingling. There are evidence-based interventions, flexion distraction technique, where the patient lays down on their stomach, as you can see here on the right side of the slide, and we can actually distract the spine to create more of a vacuum to essentially create some mobility with that disc and bring that disc away from the spinal cord and nerve roots. And there's lots of different directions that we can move the bottom of that table to help alleviate the symptoms and improve overall mobility in those segments where the disc is herniated. So there are evidence-based solutions. There's also something called spinal decompression. It's a little bit different than flexion distraction, where we're actually, again, separating out those segments in order to decompress the spine and create more of a vacuum for where that disc is to bring that disc away from the nerve roots. These are all non-surgical techniques that we use in order to help patients from going into surgery and under the knife. You know, low back surgery, I remember the Agency for Healthcare Research and Quality studied low back pain surgeries, and they found that only 1 in 3 surgeries were considered to have a successful outcome. So if you can avoid surgery at all costs, do it. Now, there are indications for surgery. You've got irretractable pain. You've got neurologic deficits that are progressing. You've got what's called cauda-equina syndrome, where you can't control your bowel or your bladder. Hey, you're a surgical candidate. Like, we cannot help you. That is on to the surgeon. But for the vast majority of patients who have disc issues, a lot of times conservative care can help. When we think about the evidence around how we treat acute, subacute, and chronic low back pain, this comes directly from the medical literature. This was a clinical practice guideline published in the Annals of Internal Medicine. And here's what their first recommendation was as it relates to acute, subacute, and chronic low back pain. Clinicians and patients should select non-pharmacologic treatment with superficial heat, massage, acupuncture, or spinal manipulation. Remember, clinical practice guidelines are the aggregation of all the scientific data available at the time of publication. And so this was published, I believe, in 2019. So again, you have to think about how you're managing your musculoskeletal system based on what the evidence says, not based on what the TV is telling us about what patients should be doing. Recommendation number 2, for patients with chronic low back pain, clinicians and patients should initially select, see how I bolded that, you guys? Should initially select non-pharmacologic treatment with exercise, multidisciplinary rehab, acupuncture, mindfulness-based stress reduction, Tai Chi, yoga, motor control exercises, progressive relaxation, electromyography feedback, biofeedback, low-level laser. I talked about that earlier as it related to some of the PT modalities that work, operant therapy, cognitive behavioral therapy, or spinal manipulation. Grade of recommendation, strong. By the way, we also know from the scientific literature that when these modalities, based on how the patient is presenting to us, when these modalities are combined for a multimodal approach, meaning we're doing several of these interventions all at once, the outcomes are substantially better. Now, talked earlier about guideline discordant care, talked earlier about all the commercials that we see, I talked earlier about going to your primary care physician and getting drugs first, talked about how the Journal of the American Medical Association says that too many clinicians are practicing guideline discordant care, costing more disability, more cost. Clearly, this is what the evidence says. Annals of Internal Medicine, one of the premier medical journals on the planet. Speaking of premier medical journals, The Lancet took 3 clinical practice guidelines, one from the US, the Annals article, one from the UK, and one from Denmark, and here's what they said. The reduced emphasis on pharmacologic care is shown by the US guideline, which recommends non-pharmacologic care as the first treatment option and reserves pharmacologic care for patients for whom non-pharmacologic care has not worked. These guidelines endorse the use of exercise, so does the Danish and UK guideline, and a range of other non-pharmacologic therapies alone and in combination, such as massage, which is in the US and UK guideline, acupuncture in the US guideline, spinal manipulation in the Danish, US, and UK guideline, Tai Chi, which is in the US guideline, and yoga, which is in the US guideline. So here's the summary, guys. Exercise and spinal manipulation for low back pain are recommended in all 3 international clinical practice guidelines. Chiropractic is not a belief system. It's an evidence-based profession that can help a lot of patients who are dealing with acute, subacute, and chronic spine-related disorders. Do we help everybody? No, of course not. No one does. But this idea that chiropractic, I believe in chiropractic or I don't believe in chiropractic, is just old school thinking. We know from the evidence it works. We know from 125 years of anecdotal data that when it's applied correctly, you've got a good provider like any other healthcare provider, it works. Like, let's use the evidence. Let's not be biased. Let's use the evidence to make the best healthcare decisions for ourselves and our families. Okay, next, shoulder pain. The most common complaints that we see are typically going to be what's called impingement syndrome, or rotator cuff is not stabilizing, which is a stabilizing group of muscles in the shoulder. They're not stabilizing our shoulder properly, so that when we lift our arms, some of our tendons, specifically the supraspinatus and infraspinatus tendons, get impinged. That creates pain, that creates inflammation. And so how do we manage that case? You go back to the recipe. Okay, do we have full joint range of motion? Do we have appropriate muscular flexibility? Many times our subscapularis, one of the rotator cuff muscles, is really, really tight because we're doing this all day long. We're internally rotated, we're at our computer. So do we need to gain flexibility there? Of course. Do we have good activation of appropriate rotator cuff muscles? Is our supraspinatus depressing our humeral head, allowing our shoulder joint to move properly as we abduct our arm? And so all of these components come into play during the evaluation, and then it's just applying the appropriate recipe, range of motion, flexibility, proprioceptive rehab, modalities to decrease pain and inflammation, and strengthening and conditioning in order to get rid of the problem. Bursitis is that little fluid-filled sac that sits between a couple of different bones that when this joint's not moving correctly, it gets compressed and irritated. Again, you're probably going to follow the same or similar recipe in getting this thing resolved. The key is to control the shoulder stabilizers, the rotator cuff, so they function properly in order to resolve the condition. Listen, anybody can go to the orthopedic surgeon and get a cortisone injection. It hurts like a bear when you're getting it. A couple days later, your shoulder feels great. Have you fixed the shoulder? 100%? No, you've not. Next condition that I want to talk about is knee pain. Again, a very common condition. Probably the 2 most common conditions that we see in our practice is what's called patellofemoral pain syndrome, where the kneecap is not tracking properly when the quadricep muscle or front thigh muscle is contracted. That's a very common thing that we see, especially in athletes and runners, even people who are in the gym all the time. Also meniscal injuries, where that cartilage, you can see here where it says medial meniscus. The medial meniscus, very commonly, that cartilage gets irritated, sometimes even torn. That's also a very common problem. Patients present with both of these conditions. When you have a meniscal injury, typically squatting all the way down is really, really hard. So if you've got front of the knee pain, that's probably going to be more patellofemoral. If you've got deep-seated knee pain on the medial side, on the inside of your knee, that's really hard to locate and you can't really pinpoint it with your finger. That's probably more a meniscal issue. When it comes to the biomechanical deficits with patellofemoral pain syndrome, believe it or not, the functional deficit is that most of the time you've got a weak gluteal muscle complex, meaning your tush muscles are not functioning properly. It's not stabilizing your femur, which is the long bone of the thigh, and therefore it's causing problems in the way the kneecap interacts with the quad muscles. So believe it or not, the pain is in the front of the knee, but the problem is in your butt muscles. So again, symptoms and function, 2 different things. You go to an appropriate healthcare provider who knows these things, they're going to rehab you the right way. A meniscal injury, a common treatment many times is surgery. Sometimes surgery is indicated. Sometimes it's not. There's been studies that have shown that conservative care for meniscal injuries can help patients function. I have 2 meniscal tears, 1 in each knee. I ski, I lift, I work out, I bike, I run, I do all the things that I need to do. Does it act up every now and then? Yes. Do I have all my cartilage in my knee? Yes. I don't want any cartilage removed. That's a personal choice. There are indications for meniscal surgery. Those things where the knee locks up, you can't get full range of motion, you've tried conservative care, it's not helping you, you probably need some level of intervention. Maybe it's something like PRP, plasma-rich platelet therapy. Maybe it's stem cell, some new emerging treatments. Maybe it's hyaluronic acid. Those are less invasive than surgery. But if those things don't work either, you may require surgery. It's about getting to the appropriate healthcare provider, trying conservative care first, and then going to the more invasive therapies when the less invasive ones don't work. Glute pain is a common thing that we're seeing in our practices as well. People are sitting all day long. They're not activating their glutes. They're weak. They're tight. And so piriformis syndrome, where the muscle, the deep muscle of the glute clamps down on the sciatic nerve and creates numbness, tingling, and also leg pain, both gluteal pain and pain down the leg. It's actually a really simple thing to diagnose. There's orthopedic testing that we do to test the spine to see if the leg pain is coming from the spine. And there's orthopedic and functional screens that we do to test whether or not this problem is coming from the glute, from the deep glute muscle. These are relatively easy problems to solve, guys. This is literally not rocket science. But you've got to be able to have an accurate diagnosis to know where the pain is coming from, understand the functional deficits that are causing the symptoms, and then just applying the rules of good musculoskeletal health. So if you've got deep glute pain and you've got some leg pain, you may not have a disc issue. You may not. You may have a sacroiliac issue, which is the connection between the sacrum, the tailbone, and the hip bone, the ilium, the pelvic bone. You may have a problem there. You may have a problem in both of those areas and the glute. So it is multimodal. Like, you could have multiple things that are causing your problem. The key is to make sure you've got someone who's a good diagnostician who can evaluate all those areas, and then just address it from a treatment perspective, what needs to get done. Shin pain, we see this a lot. It's called anterior tibialis syndrome or shin splints. It's very common, especially in athletes and runners. Heel strike, you've got 10 times the body weight that's landing on your calcaneus, on your heel bone. Your anterior tibialis muscle, which is in the front of the shin, has to decelerate the foot so your foot doesn't slap every time your heel hits the ground. That eccentric contraction, the lengthening of the muscle while still being contracted, creates a significant load on the anterior tibialis, and that can create stress where the anterior tibialis inserts on the tibia on the bone. And so, again, it's a painful condition. It can be solved with following the rules of good musculoskeletal treatment. But one thing to look out for here is that if you're not managing this the correct way and you're still continuing to run, you can develop stress fractures, which are much more difficult to deal with. So if you're a runner or an athlete and you do have an anterior shin pain, get it evaluated sooner rather than later, get the right treatment. And if you're not responding, get imaged. X-rays will not show shin splints in the early stages. You would need either something like a diagnostic ultrasound or even an MRI. CAT scan can show it as well, but I like MRIs in that regard because you can also see what's called the edema within the bone. That's that white area. That's swelling and inflammation in that white area of the bone. And that big dark line across the tibia is the actual stress fracture. So there's a lot of detail that can come from an MRI, which I like to use. Plantar fasciitis or foot or heel pain, again, a very common condition. We see this a lot in runners. There are multiple biomechanical problems that cause this. One is when your foot intrinsic muscles are not strong enough to stabilize the foot when you're walking, and you pronate or your foot deviates towards the inside, that pulls on the plantar fascia and creates stress and inflammation, which then creates fibrosis, which then decreases the pliability of the plantar fascia, which then again causes more pain and inflammation in larger areas of the plantar fascia. Another challenge with plantar fasciitis is that you've got a very tight calf muscle and Achilles tendon pulling up on the calcaneus, on the heel bone, also creating stress on the plantar fascia, again creating inflammation, fibrosis, less flexibility of the plantar fascia, less pliability of the plantar fascia, and the cycle just repeats itself. Simple ways to treat this. Again, you're going to follow all the good rules of musculoskeletal health, but stretching out the Achilles you may require an orthotic to support your arch so that you're not pronating. Lots and lots of deep tissue work and modalities on the plantar fascia, strengthening the intrinsic muscles of the foot, all very important elements of treating plantar fasciitis. Elbow pain, again, a very, very common problem. Lateral elbow pain or medial elbow pain. Lateral elbow pain is called tennis elbow. Medial elbow pain is called golfer's elbow. Tennis elbow many times is caused by lack of range of motion in the shoulder joint. So tennis players or racket athletes tend to use more of their wrist, which creates more stress on the lateral muscles of the elbow. So if we address the biomechanics of the shoulder and we do exercises to strengthen the muscles of the elbow, that can be extremely helpful. A couple things I also want to mention about tennis elbow and golfer's elbow. It is not an acute inflammatory response typically. A cortisone injection is not going to fix that problem. It is a degenerative condition. When they've looked at the tissue under a microscope, it's not acute inflammation that's causing the problem. It's actually tissue degeneration. So how do you solve that problem? How do you regenerate the tissue? How do you strengthen the tissue? You do what's called eccentric exercises. And I don't have time to demonstrate this today, but if you see this middle picture right here, this is called the Tyler twist exercise. So you do the Tyler twist exercise for lateral epicondylosis, and you do the reverse Tyler twist for medial epicondylosis or golfer's elbow. I mentioned Tim Tyler earlier. Tim is one of the most well-published physical therapists in the world. He actually developed this exercise. By the way, I got no skin in the game, guys. I don't get royalties from Tim. I don't get royalties from TheraBand or their flex bars that they sell. I just know that it works. And he published a paper on it, a really strong scientific study on it. So again, if you're dealing with these issues, you still follow the rules of good musculoskeletal health. You still need to improve your range of motion, improve your proprioception, do the PT modalities to decrease the chronic inflammation. But in your rehab program, this is a key exercise to help get you better and keep you better. Carpal tunnel syndrome is another one that we see a lot of. This is where you're experiencing numbness, tingling, pain shooting in these first 3 digits of your hand. The mistake that most providers make is that they think it's just entrapment of the medial nerve right here in the wrist, but most of the time it is a double or triple crus injury. It could be coming from the nerve root compression in your neck. It could be coming from compression of the median nerve at the elbow, and or it could be coming from compression of the median nerve at the transverse carpal ligament in your wrist. So again, kind of the secret sauce here, you guys, is if you have those symptoms, you must make sure that your healthcare provider is evaluating every single clinical pathway from your neck all the way down to the tips of your finger. If they're just looking at your wrist, run, scream bloody murder, and find a healthcare provider who actually knows what they're doing. You know, that's just how it is. There are a series of exercises that you can do. Surgery, again, kind of equivocal as the outcomes. You're going to cut the transverse carpal ligament. You're going to get an inflammatory response and fibrosis right over that same area. So the idea is, can we address all the areas of compression, neck, elbow, wrist? Can we do nerve gliding exercises, active exercises to help the nerves go through those regions of compression? Can we do other soft tissue therapies to, again, decrease the level of compression in those regions? And can we keep you healthy with a conservative care intervention? That's always what we want first. Headaches, again, a big thing that we see here. There is something called rebound headache where it actually comes from you taking, not you personally, but people taking too many analgesic pain medications. It's called rebound headache. So the more you take, the more headaches you get. We know from the evidence, cervicogenic headache, tension of headaches, headaches that start from the back of your head, around your temporal region, even from the top of your head, those patients respond very, very well to conservative care. All the things that I talked about, spinal manipulation, soft tissue work in all the regions, temporalis muscle, suboccipital muscles, all these areas in order to help decrease the pain in that region and the referred pain coming into your head. So I've covered a lot in a relatively short period of time. If you guys are interested in learning more about what we do, we've got amazing social media where we walk through a lot of different interventions and treatments that we do to help the general community learn about how we help to take care of patients. If you want to learn more about our clinic and follow us on social, just take a picture of that QR code, just put your camera up to that. It'll take you to our website and you can learn more. So when people are on stage and they get the hook, I think Dr. Birch just showed up to give me the hook because I've been talking and talking and talking this whole time. I think you all can tell that I'm extremely passionate about all of this. I want the general community to be informed about how to take care of themselves, and I truly hope that I've helped to do that for you guys today. So thank you for giving me your time and your attention. So I'll open it up to questions.
Thank you so much, Dr. J. We really appreciate you today, and we want to let everyone know that this webinar was brought to you by ASFA as an educational webinar on the pain epidemic and how to manage pain. So at this time, if you have any questions, you can go ahead and place those in the chat, and either Dr. J or Dr. Fritz will be able to answer those. Thank you so much.
Okay, so first one here actually seems like a technical question. This is recorded as well, correct? Stephanie, just wanted to make sure that this was being recorded. Perfect, yes.
Yes, we are being recorded, yes.
Perfect, yep. Seems like there was some connection issues for some people, so just wanted to ensure that. So that should be made available for everyone else to go back and review. Should they like. I've been answering questions this whole time throughout this presentation as well too. So if you have any more, feel free to fire those off, and then Dr. J and myself can answer those as appropriate.
Yeah, and maybe Dr. Birch, if you want to put your email in the chat, if somebody has any questions, they can email you directly.
Yes, absolutely. So can you speak more to urinary issues associated with herniated disc? So that gets more so into the realm of any sort of neurologic compromise of the spinal cord. And as Dr. J was saying a little bit earlier, the main concern there is Cauda-Equina syndrome, which is an emergent scenario. If you find yourself losing any sort of bowel or bladder function, that is a 911 call, and that is a trip to the emergency room, and need to be aware of that. Anytime that you start to exhibit those symptoms, it's important to get that emergent care right away. Let's see here. Advice for those with osteoporosis with respect to chiropractic treatments. Good question. So osteoporosis is not necessarily an absolute contraindication for chiropractic manipulation or those adjustments in general. It's one thing to make sure you work with your primary care provider to know exactly how advanced the osteoporosis is. And it's up to you and your clinician to ultimately determine if manipulation is an appropriate treatment modality for you. I have had plenty of patients who are osteoporotic, and they do fantastic with manipulation. Obviously, the big concern there is any sort of other skeletal structural damage. But again, you make sure that this is an appropriate modality by going through a thorough history, a thorough examination to make sure that it's right for you.
I love that answer. And if I could just add really quickly, it's important that we treat people, not parts. And, as it relates to, osteoporosis, it is, as Dr. Birch said, really important that you work with your primary care physician to get the interventions that you need for improving your bone density, because there are evidence-based solutions out there, resistance training, vitamin D, calcium, all of those nutritional things that also can be done to support you. And if medical intervention is required, great. But it is important that you have a really good approach to osteoporosis, so you're not at greater risk for really bad injury in the future.
Awesome. I've had 2 frozen shoulders, both of which required lengthy PT. I never want to experience a frozen shoulder again. How to prevent that? Good question. So frozen shoulder syndrome is more so that loss of that mobility within the shoulder, and that becomes the main goal there, is the preservation of that. So working with the end range of what your shoulder is capable to go to ultimately bumps up that threshold over time of where that range of motion is able to be increased. And you do that through specific exercise loading in all the ranges of motion of the shoulder, going forward, backwards, internally, externally rotating, in order to help prevent that. The last thing that you want to do is immobilize that joint, because when you immobilize it, that's when you get more fibrosis that occurs within that shoulder. And then slowly over time, you'll start to notice that that range of motion decreases, or that pain-free range of motion starts to decrease. And that's what accelerates the range of motion, or accelerates the degeneration of the range of motion. So the short answer to that is keep it moving. Keep it moving in a safe and appropriate manner. Work up to that point of discomfort. You don't necessarily have to push through any sort of pain threshold. The no pain, no gain is one of those theories that often gets, I put the kibosh on as soon as I see someone in my clinic, but just keep it moving as much as you're able to. Okay, nervous about spinal manipulation because I have bulging disc and herniated disc where there is narrowing of the space between the disc and spinal cord. If I went to a chiropractor, wouldn't this worsen the question? Wouldn't this worsen the condition? Excellent question here. So as Dr. J mentioned earlier, when we're dealing with disc herniations, there's multiple ways that we can go about treating those. You can do the spinal manipulation, which is that classic clicking and popping that the chiropractors are known for. And actually that has good evidence around it as well for disc herniations and disc bulges. But as he was alluding to earlier, there's other treatment modalities like deflection distraction, where we look to create that vacuum in that disc space to kind of help the disc start going back to where it needs to go and coax it that way. There's other things that you can do as well as I just mentioned end range loading for the shoulder. You can do that for the lumbar spine as well and find what's called a directional preference, which is where your body wants to move in order to help provide that symptom relief. If you start training that position, you go through that examination to find out which way your body wants to move, and you track that by increased function or decreased symptoms, multiple ways. You find that and you train that, those discs respond.
Great answer.
Okay.
And I think they want us to wrap up and do the final slide, and we can answer any questions afterwards, Dr. Birch.
Absolutely,
so
yes.
We have a slide that's up, and I think Stephanie wants to come back in.
Mm-hmm.
Thank you so much. I really appreciate you both just answering all the questions. And we have so many people who are so interested in moving forward with being able to alleviate their back pain and just pain, period, all throughout their body. So I wanted to thank everyone for joining us on today. Thank you so much to our presenters. Thank you to everyone in our audience. We had a great time listening to Dr. J on today and him giving us so much helpful information about how we can remain healthy and manage our pain. So there are additional resources with ASFA, with our Foreign Service Benefit Plan for massage and chiropractic therapy. You can go on our website, www.asfa.org/FSB/alternative benefits. Also for care management and support for members with chronic pain who are trying to avoid the opioids that Dr. J spoke about, the pills. You can also go on our website, the www.asfa/FSB wellness programs/manage specific conditions/pain management. So the information is here, and this webinar is being recorded. So if you needed to go back to that and get those links, you can. And we want to remind everyone that ASFA's FSB plan offers 50 visits for massage therapy, chiropractic, and acupuncture per calendar year. And so, and that is as long as you visit a licensed facility to receive those services, and members will be reimbursed up to $60 per visit. So we want to encourage everyone to take care of yourself. And if you are a ASFA member, if you do have our FSB plan, we encourage you to take advantage of those chiropractic visits, take advantage of those massages, because they can only help to heal your body. So that is all. If Dr. J or Dr. Fritz has anything that they would like to add before we close out.
I just want to commend you all for doing a great job in taking care of your employees and your team and the people who are part of your organization, because not every group does that. And I think it's great that you're providing benefits that are really going to make a huge difference in people's lives. So thank you for that. And thank you for doing right by your people.
Thank you. Thank you for being here as an expert to help our members and help the outer community. So thank you so much.
It's our pleasure. Thanks for having us.
All right. Thank you. Thank you, everyone.
Okay. Got one other question here. How can I differentiate the quality of care of acupuncture therapists? That all actually it comes down to a personal preference. There's a lot of acupuncturists who are people who seek acupuncture for many different things. And that gets into the school of, Eastern medicine versus Western medicine. I can't speak too much on acupuncture as I am not a licensed acupuncturist. I am certified in dry needling, which is similar, but follows that Western thought process. And if you actually look up the points that are typically used for acupuncture treatments, and you overlay that with the anatomy that would be targeted in dry needling, there's a pretty good overlap. Somewhere around 87% of those points are similar. So there is a lot of evidence that surrounds dry needling and that surrounds acupuncture. But ultimately, when it comes to finding an acupuncturist and a physician in general, you just got to find one that is appropriate for you and you have a good feeling about. You want, someone that meets your values and you feel would take proper care of you. So that's the advice that I can give with that.
And I would just add one thing. That's a great answer, Dr. Birch. Thank you. And I would just add, there are probably 3 questions that you can add when you're talking to your provider. The first question would be, what's my diagnosis and the functional issues causing it? Question number 1. Question number 2 is, what is the evidence around the intervention that you are suggesting? If you go see Dr. Birch and you ask that question about whatever condition or whatever treatment he's applying, he's going to be able to share with you exactly how he knows these things work. And then the third intervention is, what are the side effects or risks of the interventions that you're recommending? And if you ask those 3 questions and you, to Dr. Birch's point, feel good about the answers that you're receiving, you've probably got a healthcare provider that aligns with what you need. If you're not really getting strong answers, then you might want to seek out a second, third, fourth opinion.
Awesome. Next one here. Can you provide massage providers for us? I'm actually still relatively new to the area. So, Dr. J, do you have any recommendations around here for good massages?
It actually might be best for them to go to the plan links, and they could probably find someone who's part of their plan to get a good massage therapist. So I wish I could give you a better answer, but even though I've been here a long time, I'm kind of like Dr. Birch. I don't know too many massage therapists in the area. If you find a good one, they're fantastic.
Yeah. And last one, it looks like we got here. Do we have to meet the yearly deductible before you get the benefits? That would be a question that would be better served for Stephanie here.
Yes. And I did see that question. And if you are a member of the plan, please reach out to us and we can go ahead and let you know that information. Our phone number is 202-833-4910. And we can go ahead and let you know everything about the yearly deductible. And I do not believe that you do have to meet the yearly deductible, but just to confirm, please reach out to us. And that also is at AFSPA.org. And we have our health experts there who will be able to answer any plan-related questions. And again, that phone number is 202-833-4910.
Awesome. And that looks like the questions that I am seeing on our end. So I just kind of wanted to point to any further resources here. My direct email is bfritz@kaizo-health.com. Feel free to reach out if you have any other specific questions. Additionally, that information, as well as our 4 clinic locations surrounding the DMV area, are all located on our website. As Dr. J mentioned earlier, we are very active on social media. You'll find opportunities to learn more about conditions there and some helpful tips that the general population can benefit from as well. But if you have any further questions or would like any more information, feel free to check out our website and feel free to email me and I will get back to you typically by the end of the business day. I'm pretty good about that. So.
All right. Well, thank you so much again for everyone. We're going to go ahead and close out. And to answer that question, I was just informed that there's no deductible to receive benefits. So you should be able to go ahead and find your chiropractor, your massage therapist, whomever. And as long as it's covered through the plan benefits, you should be able to do that. So thank you again. We really appreciate you. At this time, we're going to go ahead and sign off. We really appreciate everyone's participation, all of your questions, and we sincerely hope that everyone has been informed and enlightened about pain management today. Thank you again and have an awesome day.
Thank you. You all take care.